Hi, I'm Steve Simpson, Professor of Pulmonary and Critical Care at the University of Kansas and Director of our Medical Intensive Care Units at the University of Kansas Hospital.
And I'm Arut Pal, Associate Professor of Internal Medicine at KU and a hospitalist at the University of Kansas Hospital.
We're here to talk about severe sepsis, life-threatening organ dysfunction due to a dysregulated host response to infection.
By the end of this video, we want you to be able to identify and measure key outcomes of severe sepsis recognition and treatment. So, Stephen, what are the key principles that we want to identify and measure in the management of sepsis to know that we're doing a good job?
Well, just like with any disease process or anything we do in life for that matter, we want to identify what we're trying to accomplish. Or in other words, we look for what the outcomes are that we're trying to achieve. With a disease process, something that involves people, we want to identify what we call patient-centered outcomes, meaning the things that we want to watch for are the things that patients desire or want or need. In the case of severe sepsis, that probably means whether they live or die. We call that mortality, obviously. It may mean how long are they in an intensive care unit, or do they even have to go to an intensive care unit, and how long they're in the hospital, and last but by no means least, what are the long-term sequelae of severe sepsis, and are we making a difference to those things? Neurological impairment, impairment to do activities of daily living. We call those patient-centered outcomes. Now, in order to improve our performance, though, we have to not only look at the patient-centered outcomes, but we have to focus on some process-centered outcomes. We need to identify what are the things that are parts of our process that we know make a difference to those patient-centered outcomes. Those would be things like how fast do we give antibiotics? Did we give enough fluids, and did we give them fast enough? Did we measure our lactate, and did we track it until it gets better? We do all those things because we know that they affect the stuff that the patients actually care about. Now, the important thing is that we have to measure those. If you can measure something and identify the level at which you're performing now, then you can change it. We can look and we can say, what is our average time to give an antibiotic? Because if our average time is 4 hours and our desired time is 1, then we have a goal to shoot for in changing those. So measurement is key. Once we've measured, we want to measure at baseline. We want to know how we're doing now. And once we've done that, we want to evaluate those outcomes and ask ourselves, take a good close look in the mirror and ask ourselves, are we doing as good as we need to do? Are we providing the optimal treatment for the patients that we need to provide them? Once we've done that, most often I have found, every time I look at this, we'll find something that's lacking in what we're doing. And then we need to do what? We need to change something. There are some principles, basic principles that we follow in how we change things, and we use some things called Pdsa Cycles or small tests of change. We change a little something, and we monitor, and we measure, and we determine whether we made a difference.
We've done a lot of Pdsa cycles, and the P is plan, D is for do, S is for study, and A is for act. Is that correct?
That's absolutely correct. So you plan what it is that you need to change, you change it, or you do, you study whether that change had an effect, and then you alter the plan or repeat the cycle. And you do it in small increments. You don't have to bite off the whole world of sepsis at one time, but we do these things in small little chunks because little by little gets us to where we need to get, gets our patients to where they need to get, so we improve their survival and decrease how long they have to stay with us in the hospital.
Are there databases locally or nationally that we're a part of?
There actually are, and as a matter of fact, the Kansas Sepsis Project has been around for several years with a sepsis quality improvement tool, which functionally is a database about which you can quiz yourself over how you're doing taking care of an individual patient and how that's gone, and then cumulatively look at how you've done on all your patients and compare yourself to other hospitals across the state of Kansas. Works really nicely.
And that's critical in quality improvement. You don't know where you start unless you can measure data and then be able to track your performance throughout the process.
That's absolutely correct.
Well, that brings us to the end of our series of videos on severe sepsis. In this final video, we've talked about how to track performance. Thank you for joining us.
To attend a live training session and to learn in more detail about diagnosing, treating, and continually improving the quality of care for severe sepsis patients, visit our website at www.kumed.com/sepsistraining. For the University of Kansas Hospital, and I'm Steve Simpson with Arut Powell, and we want to help you stop sepsis.